Thank you. It's an honor and a privilege to be here, and thank Jeff and Shiv for inviting me here, and been enjoying the conference tremendously, and certainly, at least for me, it has been an eye-opener in ways more than one. I was asked to talk about ionic magnet underlying neuropeptide in arrhythmias, and actually, we all know that there are more than simply norepinephrine and acetylcholine as neurotransmitters. There are a number of neuropolypeptides, such as the one that I just mentioned, that can play a role in arrhythmias. And here's just a brief list. And these are the results available in the literature that I put it out, and to look at the ion channels that those polypeptide can influence, that and neuropeptides certainly can affect in the pacemaker current that potentially can be arrhythmogenic. And in the last about 5 to 10 years, our work has been focused on one of the important polypeptide that is commonly believed to release during vagal stimulation, which is VIP. It's abbreviation for vasoactive intestinal polypeptide, because it is so named because it was first described in GI system by and is 28 pair base polypeptide. The first project that we raised our awareness to its importance in atrial arrhythmia is a project we did a while ago, looking at the vagal effect on electrical remodeling. And at that time, there's positive data to look at enhanced vagal activity on the electrical remodeling. So we did a very simple project, simply duplicate what the people have been doing and doing rapid pacing and look at the ERP changes over time with rapid pacing. To our surprise, let me see, where's the, okay. So as probably not much electricity. Have it? Okay. All right. And this is time axis, and this is atrial electrical refractory period, effective refractory period. This axis is delta, i.e. changes or shortening in the refractory period over time, pacing. Okay. And as we expected, this is the baseline. Okay, and we expected that with over time, with rapid pacing, there is progressively prolongation or shortening of ERP. The shortening gets more pronounced as time goes by. Okay, then we give atropine during pacing. I would think should be returned to baseline. Okay, I'm sorry. This is baseline. And this is with vagal stimulation. Certainly, vagal stimulation accelerated the remodeling process. And we hypothesized initially that with atropine, this progression of remodeling should return to control. But it didn't. And this is, panel C is just a different way of presenting the same data, looking at the percentage changes, and this is absolutely shortening, okay? And just somewhere in the middle. And when we give VIP antagonist, now it's compared to the baseline now. So that's a very first project, which we published a few years ago, that indicating there is more than simply adrenaline or the acetylcholine. And there is also some corroborative data in the literature by Sunny Post group looking at the VIP effect on the maintenance of atrial fibrillation. They put the they use acetylcholine-induced atrial fib and also stimulates the GP, and indicating that, showing that the process of atrial fib induced with rapid pacing in the setting of acetylcholine application is prolonged with stimulation, which can be reversed with VIP antagonist. Again, indicating a possible role in polypeptides such as VIP in the neuromodulation of atrial arrhythmias. This is data we just published last year, that we went one step further, looking at the cellular and the ionic mechanism of VIP, or what happened in the cellular level. So we demonstrate with VIP perfusion that with optic mapping, that this is the line, okay? This is based on actual potential recorded with optic mapping, okay? And we progressively increase the concentration of VIP. There's very nice and significant shortening abbreviation actual potential, and which can be reversed during washout. So it's not artifact because the cell is now doing well. And that's just an example, and this is composite data looking at the different pacing cycle length, okay, and the different VIP concentration. They're consistently showing that the VIP dose-dependently abbreviate actual potential, which can be reversed after washout, although sometimes the washout is not necessarily very complete, like here. It doesn't come, but definitely the washout phenomena, which actually is mechanistically important, why it didn't go. And also, in addition, it increases the heterogeneity of actual potential duration, which in part we interpret it as the homogeneity of VIP receptor distribution among cells. Only 1/3 myocardium, at least in the atrial myocardium, express significant VIP receptor that we can pick up with immunofluorescence, okay? It doesn't mean it's zero expression, it's just not enough to be picked up. And more interestingly, that the distribution of actual potential duration and have undergo a shift from this baseline. It's a nice Gaussian kind of Gaussian distribution. This is a distribution of this actual potential duration, and this the histogram. Nice, this is baseline, and that's this is a map of the color coded for the actual potential duration. It's fairly homogeneous. With increased dose of VIP concentration, you see that the appearance of a second peak, which is centered around much shorter actual potential duration. And extremely, I think this is a non-physiological concentration of VIP. It is switched completely over to the shorter peak. Okay, and that's, again, that's a one single experiment. This is composite data here. We used, for composite data, we use standard deviation of actual potential, which may or may not be a perfect way of measuring heterogeneity, but that's the tool index we used, showing definitely there is dose-dependent a change in the low to medium concentration of VIP, which increase during VIP perfusion, which the heterogeneity standard deviation as short comes down at a higher concentration, consistent with the representative case here. And also, the VIP decrease the conduction velocity. We know that shortening of actual potential with increased heterogeneity and the conduction slowing is very typical of vagal effect in atrial in terms of arrhythmogenicity of atrial fibrillation. And also the spatial heterogeneity of conduction velocity also is affected, increased with the VIP infusion. And we also look at the inducibility of atrial fibrillation with the VIP perfusion. And here is an example with optical mapping. Again, that's the isochrone map now. It's now the actual potential duration map. The color indicating the time when the local activation is. During the baseline, there is, we paste on this side of the panel, okay? And this is the overdrive pacing, S1. And a very homogeneous propagation from your left side to your right, okay? And with S2, which is more premature, you see some increase in the conduction variations in the tissue, which is expected in a normal heart. With the VIP perfusion, that's a row, you see at the even baseline have a significant slowing. And its slowing is not homogeneous. And with actual stimuli, actually you can see the formation of reentry circuitry centered around the most significant slowing. And here is the individual, that's the panel D is with the face map, is really the collaborator from Indiana University and help us develop software, and we can identify the rotor, if you will, the singularity point, that the reentry point, reentry that circling around the singularity point, which is the site of the most significant slowing. After washout, the conduction abnormality did not completely go away, because that's only, I think it was a 15-minute washout, and the VIP effect seemed to hang around. At least we did subsequent studies, need about 40 minutes totally wash out. So that is indicating that there's a significant postsynaptic process going on, which we get further interested in this part, which I show some in the subsequent slides. So we further want to examine what happened on ionic channel levels. So you see these cellular level changes that has to be able, we have to be able to explain magnetically what happened on ionic channel. So this, we first look at the delayed potassium current. In delayed potassium current, typically we think of two current. One is RKS, RKR. Okay, it turns out this is the first column is a total delayed rectified potassium current. It didn't show that this is baseline and the washout. Essentially, they overlap, and this is with VIP perfusion. So VIP accelerates the delayed rectified potassium current. That explains why it shortens the action potential. Okay, it turns out its major effect is on the RKS, not RKR. RKR essentially unchanged. And which explained actually one of the early paper on using rabbit cell that they demonstrated VIP actually prolonged action potential, because in rodents, unlike in mammal, the other mammal like human or dogs, they don't have a significant RKS. Okay, that's earlier. Let's look at the earlier repolarization current. We will look at the this is total, and that's IKUR, ITO. Okay, it turns out the VIP actually slowed down the current, inhibits current. This explains why VIP prolonged action potential in rabbit, because In the rabbit, the dominant reprising current is I told. But it's different than in humans or dogs. And also, we want to explain why slow conduction. Of course, it can, a few things can affect conduction. Gap junction, sodium channel. In the cellular level, are probably those most important acute settings. Chronically, you can have fibrosis, or that can kick in, right? So we look at the sodium channel. And VIP significantly is, this is baseline, and this is with the VIP. Okay, and here, this is the VIP here, and this baseline watch out. It significantly reduced sodium channel, and that, at least in part, explain why the sodium conduction can be slowed. Well, we show the data on the essentially VIP perfusion. So what happened to in the real physiology and endogenous, or more precisely neuronally released VIP? Do we, to answer the exact same question as you would raise with VIP as you raised with neuropeptide Y? Is the concentration too high? Is that something artificial? So I think the best way to look at it is to look at endogenous VIP release, released during vagal stimulation. So this is a paper that we just accepted from for heart rhythm. So this is essentially the protocol, and we blocked the sympathetic, of course, vagal stimulation, and we look at the first. We did a vivo, and look at the effect of bilateral sympathetic vagal trunk stimulation. The reason we have to block the beta blockers is if in dogs we stimulate the nerve trunk, essentially we stimulate both sympathetic and nerves. That it's difficult to separate them. Okay, and compare when the vagal stimulation is on or off, and look at use the shortening of refractory period as our. So we look at a different site. One is coronary sinus, right atrial appendage, and left at the arse of left inferior pulmonary vein. The reason we choose that is in humans, the pulmonary vein play an important role in pathogenesis of atrial fib, and the left inferior pulmonary vein, just when it goes transseptal animal, the easiest place to have a stable catheter. Okay, and we look at the cycle lengths, different cycle lengths, and all consistently at the baseline is green. You have shortening of ERPs, I expected, no surprise there. We gave VIP antagonist, okay, and the response is blunted, but not totally go away. It's significant statistically all across the 2-3 sites and the cycle length. And when I gave atropine, it totally eliminated. And I will have explanation why there, okay? That was very interesting. Actually, I really enjoyed the project. It's a process, as they say, the process actually is more enjoyable than the result. And I also do the isolated heart with GP. Okay, I'm sorry. I'm gonna call this optical mapping data, and this is baseline here. And again, that's actual potential duration. And this is stimulation, essentially vagal stimulation. You can see, and this is a washout. And this is with the VIP antagonist and atropine. Essentially, atropine eliminated completely vagal effect, where the vagal VIP antagonist only partially antagonized it. And that have the same effect on the conduction velocity. This is composite data, but the effect on the conduction velocity is interesting. See that both VIP antagonists and atropine almost eliminate vagal effect. So we look at that's again the effect on the during the atrial fibrillation. I'm going to skip that. okay? And showing the same thing. Essentially, most cases, VIP antagonists only attenuated, reduced vagal effect, and atropine would eliminate it completely. We look at the atropine, we then want to try to answer the question why you gave atropine and the vagal effect essentially all go away. And it turned out that VIP release, neuronal release, is mediated muscarinic receptor. If you give atropine, VIP does not release anymore. So that's why I kind of concealed the VIP effect during vagal stimulation. And that's why we did tissue contact and coronary sinus returns. I think I'm going to skip that. We also look at the signaling pathways that underlying the modulation of ionic channels. It turned out, a short answer is that it turned out is through the multiple signal, very complex signaling pathways. And I want to share one piece of unpublished data which is very interesting. We know that clinically, I like the one of the comment Shift made from bedside to bench side, that we know the VIP release increased in 3 clinical relevant situations as when related to the heart. One is vagal stimulation, as I mentioned, although that could be kind of quote unquote artificial, all right? But a clinical, definitely acute ischemia, it increased about 10 to 20-fold. Okay, it's the most one of a very potent vasodilator, and also heart failure. So we decided to focus on heart failure first. Okay, and that's a significant correlation with heart failure and incident of atrial fib. That's at the clinical background. And we look at the effect of the receptor. There are 2 receptors for VIP. One is VPAC1 and VPAC2. VPAC2 is the dominant receptor in the heart. And there was a paper, so we couldn't explain some of the effect of VIP. VIP is currently, the most time we believe it's active with cyclin AMP. Cyclin AMP effect should enhance sodium channel. It should not be inhibited. So we took a gamble, or kind of gamble, not gamble, it's just we searched for another receptor that could explain that. And then it's just during the process, we just stumbled upon a paper, maybe forgotten by many people, including also myself, because that's the only paper we can find, that they find with inflammation or activation by some agent. Monocytes, circular monocyte, can express a 5-domain variant. Okay? What's more important is that 5-domain, the missing domain in the 5-domain variant, is where the binding motive for GS. So you don't have the cyclic MP and activation anymore. So what's relevant in heart failure? This is human data. We took a human data, this is normal heart. These are all human data. See, the expression pattern is dominantly 7-domain receptors, very little, if any, 5-domain receptors. Whereas the heart failure, these are end stage. Overall, is definitely there is a significant increase expression in VPAC2, we call VPAC2-5. Okay, it denotes VPAC2 with 5-domain, that variant. Okay, this is ratio. And again, here a word of caution that our data is not strong enough to say AFib adds to it. But definitely this heart failure changes that expression pattern. Here's more detailed, more data to demonstrate the same thing. We have 3 groups of patients, normal heart, kind of intermediately EF, this is EF, and really end stage. So you have a nice, see the VPAC5 or 2-5 expression is almost inversely related to the progression of heart failure, the systolic heart failure. And as I mentioned, that the missing motive, the missing segment contains the binding motif for activation of cyclic AMP and PKA pathways. And we did some, again, those are primitive. We want to make things simple initially. We just express those two variants in CHO cells, because that's, you know, as simply as I can. Again, that's the primitive data. We demonstrate without surprise that VPAC27 activates cyclic AMP pathways. You give exposed to treat with VIP, as dose response curve is very nicely. And this is baseline, and this is CHO cells expressed VPAC25. There's not much cyclic AMP produced, essentially zero. Essentially, it's the same. Whereas the interesting part here, okay, that's very incomplete data, but indicating that VPAC25 actually can activate at least one, if not more, subfamily of PTK family pathways, although this is fairly complex, as we know. And that we just use that as a screen tool, okay? We look at the overall phosphorylation, okay? And this is VPAC25, and this is the VPAC27 at the control. So they definitely have activate different pathways. So what's the, again, there are more questions than answers. So what's the significance? Number one, at the baseline, the motive to the binding site for the PTK, short of knowing exactly which one, it's there, right? How come the presence of the GS motive can suppress that? That'll be interesting to look at it, and I think we are working on it, and I have some interest data, but I'm gonna, for the sake of time, I'm not gonna present that. And how splicing process occur during heart failure? You know, what's the reaction? It's a very interesting question to me. Okay, we have some data that indicated it's related to mitochondrial dysfunction, which kind of makes sense, but we are working on it exactly. And last but not least, how that the new splicing variant contribute arrhythmiogenicity in heart failure, and we have some data to indicate that it enhances late sodium channel, which is known to relate to pathogenesis, arrhythmiogenesis in heart failure. And I'm just going to stop that. And these are the collaborators in Utah who did a lot of work here. And we had collaborators, especially I wanted to bring the Mark Ling and really help us with optical mapping system. Thank you. Very interesting.